So, good evening, everybody. I and Vinay welcome you to the National Training Program of Pediatric Hematology Oncology chapter. And since this year the program was coming on 13th Feb, we decided to combine it with the International Childhood Cancer Day celebrations, which is celebrated every year on 15th of February. As all of you know, it is a special day to help children with cancer and to try and sort out the challenges that children and their parents feel. And the ICCD 2025 marks the second phase of the 3-year campaign, that is equal access to care for all children with cancer. And this year's theme is inspiring action by focusing on solutions, showcasing collaborative efforts, regional initiatives, and community-driven activities. So for this year, we have chosen our survivorship program to showcase what we have done as a community, as a whole team of PHO chapter of IAP. So to showcase what all has been done in our country, we have two eminent speakers, Dr. Rachna Seth, who's the professor of pediatric oncology at AIIMS Delhi, and she's also the chair of the C2S study, that's the survivorship study, which is currently ongoing in our country, and Dr. Maya Prasad, who's heading the after completion of therapy clinics at TMH Mumbai. And to guide us through this program, we have two eminent personalities. I don't think they need any introduction. We have Dr. Purna Kurkure, who actually led the whole survivorship initiative in the country. She was the first one to identify this need of children requiring survivorship care, and Gauri ma'am, who's been guiding us through the C2S study and the survivorship guidelines which are coming up with ICCI. So without much ado, I would now request Rachna ma'am to kindly give us an update about the C2S study, which is ongoing in our country right now, so that all of us are aware where we have reached, what milestones we have achieved, and where are we headed to. Thank you. Thank you, everyone. Over to you, Rachna ma'am.
Thank you. Good evening, everybody, and greetings on the ICC Day that we are all celebrating. And thank you, PHO chapter, for giving me this opportunity to talk on a subject which is very close to my heart. And I think it's really gaining popularity, and all of us are really gaining interest in this field. So I'll now share my screen. Shruti, am I audible and the slides are visible?
Yes, ma'am, you're audible and your slides are visible.
So for the next 10 to 15 minutes, I'll quickly take you through this study, which is known as the Indian Childhood Cancer Survivorship Study, the C2S study. So to just give you a background, survivorship has attracted attention globally because it translates into decades of life for every child with cancer. This actually results in a growing population of childhood cancer survivors. And also the childhood cancer survivors live well into adulthood, but this comes at a cost. And the cost is well understood in the form of late effects or chronic health conditions, which is the most common form of the cost that every child surviving cancer has to pay. But for us, therefore, pediatric oncologists, the attention has now shifted from cure at all cost to equivalent cure with minimum cost. But it is also true that most of the information is being extrapolated from what has been available in the Western world. So, but then it is also, last few years have witnessed an increased momentum in issues related to survivors and survivorship in India. What I just told you, improved survival, we have to pay a cost of cure, and ultimately this culminates into various forms of late effects. Survivors are at a higher risk of reporting chronic conditions compared to their age-matched sex and control. So these are the various forms of cancer that you see, and the dotted line below denotes the control. So whatever form of childhood cancer, the survivors are at an increased risk of one of the form of chronic health conditions, which could affect any system. Popularly, these are known as the late effects. Therefore, there is a need that you have a comprehensive evaluation for these late effects, and these can be accomplished through carefully constructed cohorts, which are sufficiently large and observed through extended periods and also through collaborative efforts. We all are familiar with the major cohorts that are available and are doing extensive exemplary work on childhood cancer survivorship. And thus, we initiated this Indian childhood cancer survivorship cohort in India via the INFORG childhood cancer survivorship study, the C2S study, which was the first study of the late effect and survivorship subcommittee of INFORG. And this was envisaged in two phases, which was phase one, where we contemplated to form a registry and also to compile the treatment details, exposure details, and ultimately build up a cohort. And the phase two was planned, and this was to last for 2 years for every patient. And then there was this phase two, which was primarily going to focus on study of late effects, the chronic health conditions, and also ultimately should culminate in forming recommendations or guidelines for long-term follow-up of childhood cancer survivors. So what were the objectives? I'm going to focus on phase one, which was the first area that had to be focused on in the C2S study. So the phase one was initially planned for 2 years for every patient, and the aim was to establish a multi-center registry of children completing treatment for childhood cancer. So the registry is expected to answer the questions related to number of profile of patients that relapse, die, or are lost to follow during this period. Secondly, we have a full spectrum of cancers and demographic details of these patients. And ultimately, we will have number and profile of patients that continue to be alive and are in remission at the end of 2 years of completion of treatment, emerging as survivors and are becoming eligible for formal ACT clinic evaluation. That starts at 2 years. So this was a prospective observational study, initially planned for 5 years. We did not know how it will take off, whether there will be takers for this study. Survivorship at 10 years or 12 years ago was sort of a neglected or a not so glamorous area to be taken ahead. And then ultimately there was a lot of interest, and we have managed to get extension, 2 more extensions, and now we have ethical clearance till 2029, the study having gained the 3rd extension. So all centers were invited to participate, and the study population comprised all children less than 18 years of age at the time of diagnosis, completing treatment for a particular malignancy and in remission. The two centers first to enter into the study were AIIMS New Delhi and Rajiv Gandhi Cancer Institute at Delhi, and the proposal has undergone 2 amendments till now. The first was that initially we had envisaged to enroll patient post 3 months of treatment completion, but at the request of centers, we extended that period to 3 months. And also we shifted from physical data capture to electronic data capture, and lately we also took ethical clearance for the phase 2 studies. So inclusion criteria, I just told you these were children less than 18 years. We also left a slot for any child who was treated at other centers and having completed treatment, but were willing to sort of follow with centers running a structured survivorship clinic. They would be eligible there provided they have complete details of their treatment. So that therefore highlighting the importance of the treatment summaries, which have to be very detailed at the time of completion of treatment. So regarding the sample size, it was a convenient sample size of 500. As I told you, we initially didn't know how to take off this study. Desirable, of course, was 1,000. But I'll just be showing you how we have proceeded and what a big samples, what a big recruitment that we have now. So following, as soon as a child, this was the progress of the study. As soon as a child completes treatment, he gets enrolled. Ethical clearance, we presume that would be taken. Enrollment within 6 months of treatment completion. All details are captured, demographic and treatment, cumulative doses, exposures. All these are captured in great detail in the performers, which are structured and are handed over to every participating center. It's a regular follow-up at 3, 6, 12, 18, and 24 months initially, and then annually once they enter a formal ACT clinic follow-up. Tracking is a major part. Tracking and follow-up is a major part of this study till these patients become eligible to be part of the regular ACT clinics. The matrix that we kept for us was that all participating centers should at least enroll 80% of their patients completing treatment, and we should at least retain contact or have the details of at least 75% of these patients who have been enrolled into the study. A statistical plan was laid down, and is a part of it has been done, but the study is still ongoing. So we do have part of the data which I'll be sharing, and definitions of EFS, OS, etc. have all been documented in the study. So now coming to the preliminary results that I wish to share today. So we have about the enrollment is still ongoing, and we have 29 centers on board, and uh, the data that these have been clubbed into, you can see various color coded. So north, south, east, and west. These are the centers who are actively recruiting and giving us data. The lower 8 ones have got clearances, are either in the process of training, or they are beginning to just give us data, and the data was not mature enough to be included in this set of analysis. The other four that you see are in the process of getting ethical clearance. So they are all have shown intent, and they are all, these four are also, once they get recruited, and in the subsequent months, I think we'll have 12 more centers giving this data. So this is and the asterisk that you see is reflective of like the red ones indicate centers who have more than 500 patients. And so also like the blue ones say 250. We've just put in the volumes of, high and low and some volume centers that are giving us data. So this, if you look at this, over 4,000 patients data that I just showed you, we have over 4,000 patients that have been registered into the study. Majority are male. For the male to female ratio, as we have been showing, 3 to 4, 3:1 or 4:1 is losing its significance. I think we have been talking of this. There are many girls who are taking treatment, and this difference is being narrowed, and the male is to female ratio is 2:1 over this set of entire cohort of survivors. The age matrix is just visible, and most of our patients belong to a upper lower socioeconomic strata from the Kuppuswamy scale. So if you look at this, what are the commonest malignancies that we have that are contributing to this cohort are the acute leukemia. The ALL, of course, understandably, takes the major role, along with AML, then the acute leukemia, then the Hodgkin's lymphoma, followed by bone tumors and retinoblastoma. What is noteworthy is, surprisingly, CNS tumors that we talk of are not a major, not contributing a major burden in this cohort. The reasons that we were trying to understand is that maybe it could be the centers that are recruiting their data are not the ones who are dealing with the CNS tumors. Part of the load could be, that they are being looked after by neurosurgeons or the radiation oncologists. So these are the reasons that we are sort of extrapolating that why we have a very low, burden of CNS tumors. We did find regional variations. So of course, more representation was from North India, but generally that now from other regions also centers are getting recruited. Commonest cancer across all regions was ALL. And again, just to highlight retinoblastoma, again, we have very good and large centers in the south. But again, what you see is that retinoblastoma is generally taken by centers as reflected in this data from north and eastern. But again, then we try to analyze and answer the question was that many of the ophthalmological centers are actually looking after retinoblastoma cases. So then that could be the reason that we are getting more skewed data from the north and the eastern states. And there was a suggestion that we should sort of ask them to also become part of the C2S study. If you look at the follow-up, then this is from the years from end of treatment. And since the centers are still recruiting, so if you look at the median period of follow-up, it's about a year. But then it is noteworthy that almost 1/3 of our survivors have completed a minimum of 2 years. Therefore, they are ready for phase 2. And of course, towards the end, I will be inviting pediatric oncologists to take off phase 2 studies. So we are already ready and to take off and start many more phase 2 studies. And all of almost 1/3 have completed more than 2 years of follow-up. And we have many patients who are almost touching 500 who are more than 5 years into follow-up at the C2S study. So if from the diagnosis, if you look, then again, this period just gets extended almost 4 years from diagnosis, and we are almost 2/3 of our survivors who have completed a minimum follow of 2 years. So we have a big number of patients and a good tracking of this cohort of our patients. If you look at the outcome, which seems quite good, but then I feel that with longer follow-up, this is going to get affected. So 82% of our children, of our survivors, of these 4,000 plus survivors, are alive and in remission. We have 10% loss to follow-up, 2% mortality, and about 6% relapsed. Of these, 3% have expired and 3% are still alive, whether alive but not yet in remission and under treatment. These have been just converted into graphs because I just thought that some graphic representation of the available data that I have. The overall survival as we defined as from date of diagnosis until the time of last follow-up. So then this is what is reflective of our cohort. Also seems promising. Also the event-free survival. Again, the events that we described were abandonment, progression, relapse, or death, whichever occurred. So this is what we have for our cohort of patients. So also it was noteworthy that I just reflect on that patient or that number of patients that are already more than into 2 years of follow-up, because these are the patients who, as I just told you, are eligible for the formal ACT evaluation, and these are almost touching to the tune of 1500. This data analysis has done towards December end, and now we have almost 1500 patients who are crossing this 2 year minimum 2 year benchmark. And the period of follow-up also that you see, the median from end of treatment is almost 4 years, and from diagnosis is almost over 6 years. So now if you look at the exposures, which for us pediatric oncologists is the most important aspect. So we have tried to analyze this. This would look a little busy. I'll skip some of the parts, but I just for you to have a glimpse. So chemotherapy is our strongest exposure, and these are the diseases that are contributing: leukemia, ALL, AML, Hodgkin's, the non-Hodgkin lymphoma. Followed by the second exposure in isolation is surgery. And as you can see, germ cell tumor, neuroblastoma, blastoma, again, these are the tumors that are contributing to this modality of exposure in isolation. I'll show you how the combined multimodal exposure changes this. Retinoblastoma, again, I'll just please focus on this also because I'll be referring to this graph again in the subsequent slide. So if you look at the combined multimodal management, so again, if you look radiation, chemo, as well as surgery in combination, then here we go. What chemotherapy alone exposure, it was leukemia, NHL, and Hodgkin's, but now you come at the multimodal exposure, you have bone tumors, CNS tumors, retinoblastoma, renal tumors, neuroblastoma that are contributing to this burden of or this load of exposures that are reflected in this pie chart. Retinoblastoma, I can do a reviewing because the reason being that why this is because most of the diseases and most patients that have been enrolled are extraocular disease, and the moment they become extraocular, they have to undergo surgery as well as radiation besides chemotherapy. So that is the reason that we are getting a big load of retinoblastoma in this cohort of our survivors. Various combinations have been worked up. We have data on all this, whether you want chemotherapy, radiation, chemosurgery, in isolation, you want exposure. We have data of all these exposures with us in the survivorship cohort. We have data on the blood component exposures. We have data on stem cell transplantation. This is still very low. We need to work on this. But then again, we reviewed this in our meeting. Then we thought that maybe there are specific societies and groups which are, particularly catering to transplant patients. That is the reason that we don't have a big number of patients who are, entered into this cohort. But we need to work on this. Just coming back to this, so just to tell you the cumulative dose of chemotherapy, which is very important for us. So now we have all this data with us. For example, cyclophosphamide exposure, other methotrexate, platin, carboplatin, etoposide, anthracycline. So we have these, the major drugs which are going to be responsible for significant late effects. We know the numbers, we know the diseases. So if anyone is interested in, sort of building up a study, I'll be just showing you a glimpse of one study that has been conceptualized. So you know that how many numbers the cohort has and how many, and what are the diseases. So you can easily build up a study and, plan your phase 2 studies based on this cohort. We had a lot of challenges ranging from center recruitment. COVID took a toll on this, study as well. Issues with data entry, training, quality, and of course there was some action that we took. I'll just quickly take you through this. So once you come to center recruitment, we started in 2016. We would give everybody, we would mail, repeatedly with a big bundle of all the information, the project, the ethical clearance, even the Kupuswamy scale, socioeconomic strata, details of SMR staging, PIS, everything with the understanding that this would pose little the there will be more centers who will be willing to participate if we give them everything ready. But not in the initial years, it was not a very good start. It was sent to all. It was not, some centers needed a MOU to be signed, which required many, documents being just shared from one center to the other. And some large volumes are still not participating. And one of the major drawbacks is that C2S study is not a funded. It is a non-glamorous area. We've, approached many of the government funding agencies also, but then this is not in the priority, which we accept. So therefore, we still proceeded with this. And if you have a look at the centers that have been enrolled, so initially we did have, takers for the study, but then after that, the recruitment has been pretty slow. But then gradually we are building on our numbers. But then worth mentioning is the role of Info, the CRCs that are the clinical research coordinators that came into, started helping us with the patient tracking, etc. They had a role, and then of course the numbers also have started to increase. And of course, we are almost now into 31 center that has approached us, and we will be working with these centers. The COVID had an impact on our study as well. Its enrollment came to a standstill practically. Difficulty in recruiting new centers, as you can see in the graph. There were interrupted enrollments, but on the other hand, teleconsultation really took off from this and became a popular mode, which I think many of our centers have even now continued as a mode for patient tracking and patient follow. Just to give you an example, for KGMU, who joined the study 2016, enrolled about 208 subjects in 2019. There was no recruitment from 2019 to 23. But then after that, we restarted, we pulled up our threads, and then we reconnected with the patients, those who were left prior to COVID, and then fresh recruitment started in 2023. So that's how centers and PIs have been really been willing to participate in this important study. Initially, we were using paper forms, but there were a lot of concerns with who was entering, handwriting, missing data, was time consuming, data was inconsistent. A lot of these problems we encountered, but this was the first form that we started with. But however, we transitioned to the electronic case record forms in 2019. Intent was to overcome all the challenges, and this form looks something like this. But then there were other concerns came up as to the feasibility of online data entry, safety, ethical clearance. Many centers have till now not got ethical clearance to use online database for this study. Training and then errors, of course, were occurring even with this. But nevertheless, this became far more structured. Reproducible, and of course, and there was a drop down menu. But then, and we did have some of our challenges, which I just thought I'll show you. But these have been over the time, rectified. That there were some wrong values. Years when the study was not started, we got these dates. There were some missing values. We got some. The red ones show that we had, missing even for disease IDs, genders, age. Some doses were wrongly captured. Some radiation doses were, huge. But then this just taught us, we would go back to our centers, and once you generate your report in the database, it would come something like this. But then we would go back to the PIs and the centers via email. It was mainly an email communication, and things would be rectified after to and fro communications and meetings. And of course, we always felt that there was a need for a national coordinator because it's a big multi-centric study now, but then we are still working on this. So, but then these are just to show you the challenges that we faced initially, and they have been rectified to a major extent. I won't say that they are, not occurring, but then to a major extent, we have been able to tackle these. So now, are we ready for phase 2? Just to give you an example, we have, this data, supposing I want one disease, I just pick up retinoblastoma. I know how many patients are there. We just worked on this to show all of you all. So we have the count of patients, we have the centers who are participating and giving this data. We know what is their outcome, we know what is their exposure, and what is their outcome. So based on exposures, we know all this, then we know what are the late effects that we need to follow. So this could be one way of following your phase 2 study based on disease. The other could be a late effect based, where if you want neurocognitive deficit, you want to follow that late effect. Then we know what all exposures, example, cranial RT, high-dose chemotherapy, total body radiation, CNS brain surgeries, and then also we know what cancers are implicated. We can give you that data, number of patients, center details, so one can actually plan whatever is the investigator field. So this, we are in that stage that we would be, ready to give such data. So first study from the C2S cohort that has been now sort of conceptualized and has got provisional registration from INFORM, led by Dr. Nirmala from TMH Hospital, Mumbai, is bone health in survivors of childhood acute lymphoblastic leukemia, serial assessment and effect of intervention. This is primarily a bone health study. We had a number of brainstorming on this in our late effect and survivorship study group. So just have a look. The inclusion criteria is besides survivors, age, now patients already enrolled in the C2S study. So this forms very, it's heartening to see that we are now able to give this data to, from various centers, and this should now take off after the external review has been done for this study. So to summarize what I have just presented, C2S study was initiated in 2016, is the first study of the survivorship and late effect INFORM subcommittee. 31 centers across India have shown an inclination to participate. Demography, exposures, clinical outcomes, cohort available of the cohort, this information we have. Chemotherapy was our most common treatment exposure, followed by surgery. The C2S study is actually running on a project mode with serial extensions now that we have it till 2029. What next? I also don't know. We have discussed this also, because if it has a intent of a registry, then it needs to go on. We need to work on this also, and it will be on a wider forum that we'll take up all of this. And we need to have a dedicated national coordinator. And completing center data has been a challenge. The database needs some modification, and we are still doing this. And Dr. Ramandeep has been wished to take on this platform, wished to mention his support also, and he's been really working with on this database, and it's the longest ongoing study, and culminated in forming the Indian childhood cancer survivorship cohort. And now we've initiated the phase 2 studies, and challenges, of course, still remain, and these need to be tackled. So thank you for your patient hearing. But then before I conclude, I wish to acknowledge with thanks all the participating centers, all the CRCs, all Dr. Ramandeep Arora in particular, the Resonance team, the other members of the INFORM team, and all others who have directly or indirectly contributed as experts, as reviewers. And this has been this study in various forms has been presented at various fora, at SIOP, FOCON, and the survivorship meetings, etc. So with this, I thank you for your patient hearing.
Thank you, Rachna ma'am. Such a meticulously conducted study and such a comprehensive data being accumulated. In the interest of time, we'll move on to the next talk, and then I request the moderators to have their comments at the end of next talk. So we'll move on to the next talk, which is by Dr. Maya Prasad regarding the ACT clinic and the details.
Thank you, Vinay. I hope the screen is visible as full screen, and my voice is also clear.
Not full screen.
Oh, it's not full
This is
screen.
clear,
Sorry.
not.
Yeah. Just,
Yes.
so thank you, Vinay. Thank you, Rachna ma'am, for that excellent talk. And thank you, Dr. Banavali sir, Manas, Shruti, and everyone else who is on this session. And thank you very much for allowing me to present our experience from the after completion of treatment clinic at the Tata Memorial Hospital. So as we already heard, outcomes, we are, I think, very fortunate to be working in the field of pediatric cancer, where outcomes are steadily increasing, and there is a steady increase in the survivor population. And especially it's going to be so in the years to come. While most of the data from the West is over 85%, I think we are also not doing so badly. And probably from most centers in India, we can anticipate that around 60 to 80% of children with cancer are probably going, depending on the center and depending on the disease, going on to become long-term survivors. We also heard about the potential late effects which may occur in certain subsets of survivors of childhood cancer. because of which they need to have long-term follow-up, which is decided based on their risk of developing late effects, depending on the treatment they have received. And ideally, such care should be based on the internationally accepted guidelines and within the context of a multidisciplinary survivorship clinic. So it is with this intent that the ACT clinic was started way back in 1991. And here you can see Dr. Kurkure looking as young as ever. And initially, to start off with, it was always a multidisciplinary clinic led by 2 pediatric oncologists, also had psychologists, and there was a strong reliance on the service component with a focus on rehabilitation. Initial reports came out in 2003. There were 2 papers which were published. At the time, the population was pretty young, with a median follow-up of around 11 years, although some survivors were still adults. And around 30% of these survivors had some form of late effects which required treatment. The late effect profile was very much similar to what we would expect. There was a high prevalence of hepatitis B infection, and also a lot of children who had scholastic problems with psychosocial difficulties, which we would actually expect in our population, especially many years ago. With an increasing number of survivors of childhood cancer, and with an increasing age of these survivors, the focus gradually shifted to adolescent and young adults of childhood cancer. And we know that they require a lot of support. They have different kind of issues. So there was a lot of liaison with specialists and NGOs. And there was the formation of a peer support group of AYA survivors known as UGAM, and that has now expanded to other centers across the country and celebrated its 15th anniversary last year. In the last decade, there has been further expansion, and we've been able to add more people to the ACT team. And fortunately, we've been able to have some clinics even within the hospital, which specifically look at late effects, especially our endocrinology clinic, which is extremely busy. What was really very good during this time is the large amount of funds that we got, mostly through CSR funds, and that has enabled us to treat a lot of our children with late effects, and especially growth hormone treatment. We've also been able to provide educational scholarships to all those who have asked for it. So those are really great things. And we've been able to expand quite a bit over the past decade or so. As of February this year, we have just over 5,500 survivors of childhood cancer in our clinic. And last year, we were able to enroll 735 new children, and the footfalls are quite high, and sometimes it can be really very busy and difficult to manage. We published our data in 2022. This was a smaller number than we have now, around 3,000 survivors. And I'm not going into the details, but apart from the other late effects profile, which would be as expected, we still continue to have a substantial amount of children with chronic hepatitis, a lot of children with psychosocial issues, scholastic problems, school dropouts. We also found that our adolescent and young adult survivors are less likely to be employed than their siblings. So, I mean, I think we all know that one of the important things about knowing about late effects is that you know how to change your treatment protocols to provide less toxic exposure. So a very classical example in point is that of Hodgkin lymphoma, where the earlier radiation fields were very large. They were the mantle and the mini-mantle fields, which translated into a lot of musculoskeletal issues, cardiomyopathy, because almost the entire heart was exposed, and breast cancer as a second cancer in female survivors. And this is not just the case in our center. This is a worldwide thing that happened, that the fields of radiation were decreased with this knowledge. And there was also recognition that we didn't actually need these huge fields. So that is why, I mean, this is just for the trainees, that is why the study of late effects is so important, because you actually know what are the treatment changes that need to be made. So, and we also know that this reduction in treatment exposures actually translated into a decrease in the long-term mortality and the morbidity in survivors of childhood cancer. This is our data from TMH, and we can see that over the decades, there has been actually a decrease in the number of children who have received radiation, and the number of children who have received radiation in the past decade has been very, very little. And most of the children who received cranial radiation in this last decade are children with brain tumors. There's also been a decrease in the drug dosages, cumulative drug dosages, especially cyclophosphamide and anthracyclines, because we've been following more contemporary protocols. As a result of this, it's great to know that in the past 2 decades, children who have been treated on contemporary protocols after 2000, around 70 to 90% of them actually have no significant late effect. I mean, I think that's very wonderful for us to know. And I think this is one of the greatest things that people who have been treating patients in the 2000s would be very happy to know. This population is quite young. They are still at a risk of developing some late effects, although only some patients are going to now develop more late effects. These are the individual late effects, and as you can see, most of them are, in single digits and less than, there's hardly anything which is more than 5% prevalence. So really, the late effect profile of children who have been treated after 2000 is not very much. However, there is still a proportion of children who are high risk, and they absolutely need to receive high doses of drugs. They will need to receive radiation. For example, children with brain tumors, those with relapse disease, those with high risk sarcomas. There's no way you can get away by de-escalating treatment in most of them. So they still remain at a high risk of developing late effects. The other population which is at a high risk of developing late effects is older survivors. So we know that the older you get, you may develop certain late effects, and also certain exposures are known to promote early aging in older survivors of childhood cancer. This is our experience as well. When we looked at our adult survivors of childhood cancer who were more than 30 years of age, we found that there was a high prevalence of grade 2 to 5 late effects, which means anything that requires intervention. Grade 5 actually means death. We also did something else. I showed you the very first publication that came out from Dr. Kurkure in 2002, at which time there were 625 survivors in that cohort. And at that time, the median duration of follow-up was 11 years. In 2021, we updated their data. And at that time, the median age was 25. So from children, median duration of follow-up was 25, and their current age was 30. So they were actually a population of what we could probably in our context be termed as older adult survivors. And what we found is that most definitely the children who barely had any late effects, only around 25% of them had any late effects, which could be considered significant, but that really increased in the population when they grew older. But also remember that these children were treated in older decades. They were treated in the 70s, 80s, and the 90s. So those treatment exposures were far more toxic than they are today. There was, of course, we know that subsequent malignant neoplasms, so second cancers may increase, the prevalence may increase, especially in irradiated areas over time. So definitely the prevalence of that had increased, and also that of cardiac toxicities increased as the survivor population aged. We recently looked at the marital status of our survivors aged more than 25 years, which is approximately the median age of marriage in India. And we found that around over 2/3 of males and females were married by that time. And a lot of them actually had children as well. A lot of our survivors, as expected, have used assisted reproductive technologies in order to have children. An unfortunate thing which all of us face is that a large proportion of our survivors just don't come for follow-up after a few years. And in our cohort, we found that around 60% of patients who were actually treated in the 1970s to 1990s. So that's not because the numbers at that time were not as big. It is not a huge number, but still a lot of them actually are lost to follow-up. And if they are alive, which they probably are, they would be aging adults who could be at a higher risk of developing late effects, but we really don't even know if they're receiving any care, actually. A survey that we did found that the more common reasons for people not coming for follow-up was that they had got busy with their lives. They were busy with their job or family or school, and they were giving low priority to follow-up. And because it was a long time since diagnosis, they actually felt there was maybe no need to even follow up. How have we been tackling this problem? I think communication is key to this. We have to inform, especially the high-risk survivors, that they need to follow up, if not with us, at least with their local physician or with someone who is well aware of what are the potential concerns that may occur with increasing age. What has really helped us has been our ability to provide financial support for evaluation and treatment at our center, which offsets a lot of the cost of the travel, etc., to come to our hospital. We've also been increasingly doing tele-survivorship in certain subset of patients who have a very low risk of side effects and are educated, capable of self-managing, and will contact their local physician and manage. So the other challenges for survivorship care in India, as Madam just said, it is often difficult to transition the children from the acute oncology OPD to survivorship care, and the C2S study will hopefully really help us circumvent that problem. There is a lack of most rehabilitation services in the community, and there are lots of efforts to build those up. Most people have complained that the international guidelines are probably not easy to follow in places which don't have as much resources. But a welcome step in this direction has been both resource-adapted guidelines from ARAYA, as well as our very own Indian Cancer ICCI survivorship guidelines, which are coming. So finally, the takeaways that I would like to tell our trainees is that whenever you are in a pediatric oncology unit, first of all, you need to assess the need. So how many of your children have completed treatment? How many survivors do you have? So if you feel that you have a large enough number of survivors, then you should think about establishing a multidisciplinary clinic for survivors with a dedicated time and space allotted to them. Invest in training good support staff. And especially because, most of us balance active oncology care with survivorship care, and it's difficult to invest so much time in our late effects clinics. So if the support staff are very good and, they are able to, handle a lot of the initial problems, the referrals, etc., then it takes away half your work. And make a committed team. Survivorship care is definitely something for the long haul. It's not at all glamorous, so you really have to be very committed in order to keep doing this day in and day out. All survivors should receive a treatment summary and be told what is actually written in that treatment summary and what needs to be done as a result of the treatment summary. And we need to follow guidelines as much as possible and follow risk-based and exposure-related monitoring. And remember that the risk of a patient at upfront treatment is not the same as the risk of developing late effects. It's very important to build a rapport, and it's very important that that they do not have to do unnecessary tests or stay for a long time for their follow-up, because they should be encouraged to go back. Our survivors and their families should be encouraged to go back and continue their normal lives as much as possible and not hang around the hospital even when they come for follow-up. The great news is that a large proportion of children who were treated in the recent decades have a low risk of late effects. They should be promoted, absolutely promoted, to go back to their to a normal lifestyle, a normal school, playing, everything as you would expect a child of their age to do. But health promotion needs to be done for all children. As we just heard about those who are at a high risk of late effects, I think firstly we should try and do as standard treatments as possible during active treatment, including trying to prevent late effects, including fertility preservation in those who are eligible for it. Once they have completed treatment, institute the appropriate late effect surveillance. And always, if you are not within a multi-speciality hospital, try and liaison with specialists who have special expertise in managing late effects of childhood cancer. Most of our patients are not able to afford a lot of things, so it really helps to get funding and to partner with NGOs, to partner with peer support groups or form your own peer support group, and to try and expand educational programs and rehabilitative services. And they all should be within their, as close to their hometown as possible. So finally, on the eve of International Childhood Cancer Day, I would like to tell you that it certainly takes a village to cure a child with cancer, but it also takes a village to make sure that cure translates into long and healthy lives for our children who have completed treatment for cancer. Thank you very much.
Thank you, Maya. And it's heartening to know that it is, the survivors do not have so much of late effects. And also it is possible in a country like ours to run an ACT clinic, to get funding for it. So hats off to you and the entire team at TMH. So I think now I would like to invite Dr. Purna Kurkure. Ma'am, what inspired you to start the ACT clinic, at that point of time in a country like India, and how you managed to, make these children come back year after year for follow-up. I think we all need that guidance from you.
Thank you, Shruti, for that very important questions. Going back in the memory lane, I can say that it is the pediatrician within me which said that pediatric oncology patient needs to be looked first as a pediatrician, along with being an oncologist and giving care as an oncologist. So that inspired me. And I'm also I remember my mentor, Dr. Meena Desai, who was a pediatric endocrinologist and she was a mother of pediatric endocrinology in the country. And she had a vision, she was very well traveled, and she had seen the endocrinologists getting involved into this subject. And she inspired me to go into the depths. And I was very fortunate to visit St. Jude and see the ACT clinic running. And Dr. Melissa Hudson was then very new to the ACT clinic. And she inspired me and I could start. So that is a history. And it was very, very difficult because that concept of taking away the children from to a specialized clinic was something unknown, and everybody felt that why should we take away we as a pediatric oncologist get involved with our patients very much, and we really know them very closely. So to give up to a third space, that is ACT clinic, becomes difficult, but it is in their interest. And slowly that concept changed, and people realized, even the colleagues realized, that no, there is some advantage of having these children under specialized care. And that grew by itself. So first was the medical care, and then when there was enough mass and these children grew up, they created their own peer support group, that is UGAM. The PSYOP 2007 was a turning point when our survivors interacted with the survivors who came then not under CCI. It was then known as ICUPU. They came, the ICUPU used to hold meetings alongside the PSYOP main meeting. And there were survivors networking. Survivors could attend in Mumbai, and they got inspired. So the whole concept of taking it out into the society came with this UGAM as a prototype of childhood cancer survivor support group. So this is the whole journey. But we feel happy looking at the last decade when the late effects have gone down. But also we have to remember in this decade, how much have we added as more of targeted therapies, and many of the situations where we are trying to convert into a chronic cancer into chronic disease by continuously giving them these small molecules targeted therapies. And the next challenge is that challenges never end. I feel they always remain in front of us, and that keeps us active and going as a physicians. And the next challenge is going to be that what happens when you use targeted therapies. We learned a lot about the more intensive therapies and how you can modulate them to less intensive therapies to avoid or mitigate the late effects. Now the next challenge is going to be different one, but the challenges will always be there, and there is a place for surveillance of these children forever. That is my take on the matter.
Thank you, ma'am.
Thank you, Purna ma'am. The passion and the vision you had then is materializing now. Gauri ma'am, I would like to have your comments and also your thoughts for the entire group regarding the study that Rachna ma'am showed you, or the second center to join, and also further insights into this type of studies and moving forward for the entire PHO community.
Thank you. Thank you, Vinay. And Shruti for involving me in this very important meeting today and this symposium on the eve of International Childhood Cancer Day. First and foremost, I would like to congratulate Dr. Rachna for an excellent overview on the work done in the C2S study, having enrolled more than 4,000 patients, and also showing us now the way forward for new research in the for the survivors, looking at various late effects and doing various studies and developing a cohort, and also to acknowledge the hard work that has gone into trying to recruit more centers. But one of the things is, if we didn't have the study, we wouldn't have these 31 centers now having ACT clinics, and I think that is a very big achievement, along with Picasso, ICS having joined in the fray, and I think even CanKids is helping out. I think this has created such an awareness that new ACT clinics are now coming up in all pediatric oncology units. So I think that's a big plus. For Dr. Maya, I would like to say yours also was, both talks were really excellent, and it's really taking this survivorship to another level in India. Maya's talk also reflects about how the Tata ACT program has reached a certain level of maturity, and how they have this multidisciplinary care, how they are now looking at aging in their survivors, which is fantastic. We couldn't have thought of this 10 years ago. And then also two more very nice points she said. One is tracking is very crucial. If we think that we will just talk to them and they will come back for follow-up, forget about it. Neither here nor at St. Jude do the survivors want to come. You have to incentivize. There is no doubt about it. So everybody has their own way. The second thing was, make every visit worthwhile for them. So that was a very good takeaway from Maya. And once again say that what Dr. Kurkure has started and Maya is taking forward, and what Rachna is doing, it is showing us the way, what we can aspire for in our clinics. We can take it all forward, and we can be at par with the rest of the world. So thank you once again, and wish everybody again on the eve of International Childhood Cancer Day.
I
Thank you, ma'am.
wish to also wish everyone on the eve of International Childhood Cancer Day, and let us work together, as Gauri mentioned, under various projects, under various studies, and learn. The survivors are the biggest teachers, I would say. Learn from them all the aspects of life, science as well as the psychosocial.
Thank you, Dr. Rachna, Maya, Purna ma'am, and Gauri ma'am for those insights into survivorship. And now I would like to hand over to Manas to take the program further. Thank you.
So good evening, everyone. I hope you can hear me, Shruti. Am I audible?
Manas,
Yes.
can you do a quick pic with all the people on board? Is
Sorry?
that possible? Can you take a photograph of the whole screenshot with all the people? Or
Why
is that
not? We can do that. We can do that definitely, ma'am. We have today we have got many things that we are going to celebrate, and 2, 3 releases that we are going to do, and I'm sure we'll get the opportunity to take multiple pics there also. So good evening, everyone. I wish again all of you a happy International Childhood Cancer Day. I think the fact that you started with survivorship as a talk in International Childhood Cancer Day reflects where India has come as a cancer community and how much we have achieved in the last few years. And there is no stopping for the pediatric oncology community in India and for our children who, unfortunately suffer from this disease. And we are all geared up to do the best for them. So as you all know that ICCD is a global collaborative campaign to raise awareness and promote an increased appreciation and deeper understanding of all the challenges that children and adolescents face while they go through their journey of cancer, and not only those children, the survivors and their families and their siblings. So this day puts a spotlight to the need that all of us, try our best to give an equitable access to all the children whosoever are there anywhere in the world. And for that, to celebrate that day, we have a very distinguished speaker among us. And I will request our chairperson, Dr. Sridhar Banavali, to kindly introduce the speaker so that we can move on to the keynote address.
Thank you, Manas. And once again, best wishes on the eve of International Childhood Cancer Day. Last year, we had another good friend of mine, Dr. Carlos Galindo, who actually addressed us. And this year, I have the pleasant duty of introducing another friend of ours, Dr. Guillermo Chantada. Dr. Chantada, as we all know, is the president of the International Society of Pediatric Oncology and is also the head of outreach program of the Pediatric Cancer Center, St. John de Diu, Barcelona Children's Hospital in Barcelona, Spain. First of all, thank you very much, Dr. Chantada, for taking out time from your really busy schedule and addressing our, pediatric hemato-oncology community here in India. Dr. Chantada graduated from the University of Buenos Aires in Argentina and completed his postgraduate training in clinical pediatrics and pediatric hemato-oncology at the Hospital J.P. Garan at Buenos Aires in 2001. He also trained at the Pediatric Hemato-Oncology Service of the Memorial Sloan Kettering Cancer Center in New York, USA, and later at the Hematology Service at Hanover Medical School in Germany. So he's an associate member of the Oncology Service of the Hospital St. John de Diu in Barcelona, Spain. He is the principal researcher of the National Council of Research in Argentina. His major contribution, as we all know, are especially in the area of translational research in retinoblastoma, where he worked in the identification of innovative treatments, characteristics of tumors in developing countries, and in depicting its mechanisms of molecular dissemination. He leads the Latin American treatment protocol at the Gallup, where he is a member of the board, and he also serves as coordinator of the European retinoblastoma group, and he leads the development of an anti-idiotype vaccine for neuroblastoma in the Latin American protocol. So his other area of interest are in pediatric lymphomas and histiocytosis. And very importantly, he is also a member of the St. Jude's Global Pediatric Medicine Department, where he is the editor-in-chief of Oncopedia at the Cure for Kids portal, where we really get a lot of interesting information and the advances. He is member of the board of Latin American Society of Pediatric Oncology, and very, very importantly, is a friend of the whole pediatric hematology oncology community of the low and middle income, especially the low and middle income countries. And he has picked up a very, very apt topic in the sense he is going to speak on why do we need to do research in pediatric cancer in low and middle income countries. As we all know, most of the data that we get in the research journal is from the West, but very importantly, 80% of the children, or even 75% of the children with cancer are in the low and middle income countries. And initially we had no people to treat these children, but now with more people getting trained in hemato-oncology, more resources available, it will be interesting and important to think about research. So Dr. Galindo, Dr. basically Chentada is going to talk to us about the importance of doing research in pediatric hemato-oncology in the developing low and middle income countries. Over to you, Dr. Chentada. And thank you once again.
No, thank you very much, Shripad, and dear friends. It's always a pleasure to spend time with you, to learn from you. I really enjoyed very much the previous presentation, and I'm always a big admirer of the great work that is being done in your country. So once again, thanks for the invitation. Happy ICCD. And let me just reflect with you a couple of things. On I think you have already taught the world why do we need to do research in pediatric cancer in low and middle income countries. So I think this slide is probably redundant for this qualified audience, but we all know that pediatric cancer is different. Just to start the talk, we cannot base our knowledge on what is known from adult oncology. Our cancers are different. Our pediatric cancers are developmental disorders, not like adult cancer. We are not so heavily influenced by lifestyle habits like smoking or exposure to toxic or alcohol or drugs or hormones. Our tumors are the influence of the environment, the sun exposure and things that affect adult cancer are really more difficult to ascertain in pediatric cancer. So they are difficult or almost impossible to prevent, except a couple of tumors where we know the genetic predisposition. Our tumors are fastly growing. They don't grow in decades or years. They grow in over a few months. So the biology and the ways that we should approach are completely different. And fortunately, we have a lower prevalence. So having a lower prevalence compared to adult oncology forced us to work cooperatively. Nobody can do a big study on its own. No, there is not such a huge center in the world that can do their own research in all tumors because we have a lower prevalence. So that's a blessing because fortunately few kids get sick of cancer, and also it's a blessing because that forced us historically to work in cooperation. And our tumors, there are some geographical variations, of course. Burkitt's lymphoma, tumors related to HIV infection, for example, but these are not major. T-cell leukemia, maybe there are some difference around the world, but they are not so profound like we see in adults. And I think we have a better map compared to adult oncology to show the inequity and to show that even though childhood cancer, as you all know, is curable or may be curable in the green areas of this slide in the highly developed countries where about 80% of the children got cured. But it's not the same in the rest of the world. And as Shripad has said, this is where most children live. So where most children live, tumors that could be cured are not cured. So but this doesn't mean that if we just import what has been done in high-income country and do it in our own countries, that will work. And that's probably the big message of this talk. This won't work. If you take Kate Mathey to Sudan, that doesn't mean that neuroblastoma is going to be cured in Sudan. It's not because we don't know. It's not because we are not trained enough. It's because our problems are different. And because our problems are different, is that we need research. Because the questions that were answered in high-income countries not always are the same. And their solutions from high-income countries are not always the same for our setting. So like Lady Gaga would say, there are a million reasons why there is such a big difference in survival. One is surely, probably the most important one is insufficient access to high quality care because there is no universal health coverage. Some governments don't invest as much as they can to support childhood cancer. These all the things leads to late diagnosis. It's a term that I don't like too much, but it's really happening in our setting. Tumors that could be diagnosed early are diagnosed later than in high-income countries. There are many drugs that are essential drugs for the treatment of children, that we're going to see later, that are not available in our setting, not let alone the targeted therapy, let alone the immunotherapy. Sometimes very basic chemotherapy drugs are not available. We see, and I know you face the same reality, that our children have more comorbidity, and they come late, they were malnourished, they tolerate treatments not so well as in high-income countries. And that's a big topic because we cannot use very intensive chemotherapy on induction, for example, in Burkitt's lymphoma. We have also the issue of treatment compliance. Unfortunately, because of all these things that I mentioned, many times the family simply cannot afford the treatment because they have to pay out of their own pocket. Sometimes there are cultural barriers, many things that influence that many of the children that could be cured don't complete treatment and then relapse and die. And there is very low investment in research. Usually there is a myth that we don't need research because research is being done in high-income countries. So all we need to do is apply evidence-based medicine. But evidence-based medicine is not just using the evidence, but generating the evidence. And that is what I will try to convey today. Let me put a couple of examples. As Shipad mentioned, most of my work was done on retinoblastoma. You see here on the right, on the left-hand side of the screen, a very important study that led by Didi Fabian, where he showed that the survival on retinoblastoma is different according to the income level of the country. So that's not a big news. Everybody know that it's one of the 6 tumors that the WHO is prioritizing for cure all over the world. But I think another important thing is why there is not such a cure in low-income countries compared to high-income countries. And as you see in the slides, the reasons why are different. In high-income country, very few children will die of retinoblastoma. About 98% are now cured. I don't think any child would die of toxic mortality, of treatment-related mortality. I don't think any child abandoned treatment or very few ones. So the major reason why children die are second tumors. So later in life, right? In the 20, 30, 40 years old. So all the treatment that they are using in high-income countries are based on these premises. So there is no mortality. We have to make sure these children are not exposed to high toxicity treatment because they will be suffering a second tumor later in life. So that's a completely different story in middle income and in low income countries, as you will see. In low income countries, the major reason of children dying on retinoblastoma is abandonment followed by extraocular relapse. So we have different problems, and if we don't do research on this, we are not going to get any answers. But first we have to identify which are the problems. So this is another paper we did with Scott Howard a few years ago, showing this same picture in Burkitt's lymphoma, where you saw that is even more dramatic because if you see in high-income countries, this is a relatively old slide. So now data, because rituximab, they are even better. They are over 90% survival rate in Burkitt's lymphoma. And how they do it? Giving intensive chemotherapy, good supportive care, and then children don't relapse. And the very few that die is because they have a chemo-resistant tumor and die. In low and middle income countries, there is a different story. There is a few years ago in Central America, when they were starting treating children with Burkitt's lymphoma, they tried to use the same LMB protocol that was used in Europe. they had 40% toxic mortality rate. So 40% of the children died in the first couple of weeks. And that is a reality. So they cannot translate what is being done in high-income countries. So what they did, something that was completely counterintuitive to us, to the common knowledge, they reduced intensive treatment, and they later we added rituximab, as I know it's being done in India. So what was counterintuitive for the knowledge at that time, because we all knew that we need a very intensive chemotherapy, the Goldman hypothesis, etc., led to very bad results compared to what we had when we reduced the chemotherapy and we used rituximab early in order to compensate for that reduction of therapy and achieve better results. But that is known because we collect the data, we analyze the data, we don't try to resemble what is being done in high-income countries, and we come up with a solution adapted to our reality. And that is called research. We need to do that. We have to measure how much we improve, where we improve, and how we can improve later in a subsequent study. So there are many limitations for research in low and middle income countries. First, I briefly mentioned that before, is conceptual. We are taught that we need to apply evidence-based medicine, which is great, which is a great concept, but we forget that we need to generate evidence, because the evidence we have sometimes is not applicable in our centers. There are financial issues, of course. There are marketing issues by the pharmaceutical industry. I think there is a big inequality, because now children in high-income countries can access the new drugs for free. The pharmaceutical companies pay for the studies. Then when the drug is approved, the drug is available in low and middle income countries, and we have to pay for it. Our health system have to pay for it, when in high-income countries where they have more resources, they don't. They are subsidized by the pharmaceutical industry. So that's, I think it's a big inequality, an injustice that we need to find the ways of doing research with new drugs, perhaps positioned in a different way, like I mentioned rituximab, like anti-GD2 chemotherapy, immunotherapy. We have to find the way that we can use those drugs in our setting and do the necessary research and have access of our patients for the research. So the current problem, I think, in the world, in general, in pediatrics, it's not just pediatric oncologists. It's not that children are abused by research. They don't have access. The major problem is that they don't have access to the necessary research. We protect too much. We perceive as research is a high-risk issue for children. The IRBs are sometimes very reluctant to take the risk of including children in research studies. So and not just me, but many people around the world think that we have to change that now. The children should benefit for clinical research. It's a benefit, it's a right they have. It's not a risk when research is done appropriately. And also, I know that this is a problem in India and in many big countries around the world. There are many limitations for sharing data internationally. And as I said in the beginning, we treat rare diseases, rare tumors. If we don't cooperate, if we don't share our data with all the precautions we should take for data privacy, of course, but we need to share the data internationally, because we can move faster and we can make things happen much faster. This is in Spanish, I'm sorry, but this is about this is a newspaper in Paraguay where there was in the news that a desperate mother was looking for a drug that is not available in the country. Which was that drug? Maybe you will imagine will be blinatumomab, will be dinutuximab. No, it was actinomycin D. There is no actinomycin D in many countries around in Latin America. Or when it's available, it's extremely expensive. So we need to do research, for example, to find substitutes of a drug that is relatively easy and cheap in high-income countries, but not available in low and middle income, in many middle income countries. It is in the newspaper, a poor mother looking for actinomycin D for his child. And in the same line of knowledge, again, I just pasted the website where the FDA approved naxitamab for high-risk neuroblastoma. Then it was approved in many low and in many middle-income countries. But just look at the slide; it's only approved for relapse and refractory neuroblastoma. We need it first. We need it in first line. We need to improve the results in first line. So we need to do this reposition of these new molecules to come up with the necessary knowledge that we need in low and middle income countries. And what is SIOP doing? SIOP is, as you know, the only global multidisciplinary society in pediatric oncology. We are now more than 3,500 members, and we are all over the world in more than 130 countries. We are a non-state actor also in official relations with the WHO. And we have a couple of programs that are not just based on research as the way I mentioned before, but also in global health research, like the Global Mapping Program. As you will see here, these were the publications that we had last year, mostly in Africa and Latin America, where we could map the institutions all over the world. We are now actively working in Asia. I'd like to thank the cooperation of INFOG and the Indian Society for sharing their data. And these are the data we could come up with. So we now know, for example, how many pediatric oncologists are in every country, how many are per patient, how many patients are seen in public institutions, we know how many surgeons are there, which are the training, etc. Very relevant research that can be done in order to inform policy. And we have also the PARC program, which INFOG is one of the recipients of our support. SIOP is supporting the cooperative groups all over the world. These are the ones that we support. We have just launched our second round of funding, and we have also career awards. One of them was awarded to an Indian colleague. So SIOP is trying to support the fundamentals, the cooperative groups to perform the research. We don't tell INFOG, Cancer Africa, Gallup, which is the research they should do. We know they are doing their best, and we like to support their research capacity with some funding. So let me conclude by saying that pediatric cancer research is a major global challenge all over the world. At least for me, research is the only tool for progress. This is exactly what has been done in high-income countries, and we should do the same, but adapt it to our reality. But inequity really in access is a major determinant, and that is something that is very much difficult to influence. But now there is a strong global movement thanks to the Global Initiative for Childhood Cancer. We all share common goals, and we need for a multi-stakeholder approach. We cannot do it alone. It's not a cooperative group alone. We need every part of the society, the parental involvement, the governments, the hospitals, and the professional society support to reach that goal. So by this, I thank you. I'd like to invite you tomorrow to the second Global Oncothon that is going to last all over the day, and SIOP will share awareness, but also fundraise for PARC to support PARC. And so I was just looking at my phone because I'm waiting for the Leo Messi video to support the Oncothon. I hope we can get it on time because he's about to play. But join us tomorrow to celebrate the ICCD together. Thank you very much again for the opportunity.
Thank you, Dr. Chantada. It was an excellent keynote address where, in very simplistic way, you have highlighted the importance of research for a low middle income country. And India, I can promise that is not going to disappoint you. India is doing huge amount of work from the point of view of research, and we all have got together, and there are few people who are really driving force behind the research, collaborative research in India. And you're going to see amazing work that will come out of India in the next few years. So thank you so much. And in a very simplistic way, you have beautifully highlighted the importance of research for us. I would request you to just stay back for some time. We want to, release two very important things. Banavali sir is there, and you are there, and I'll request Dr. Rashmi Dalvi, who is the SIOP Advocacy Chair also. Ma'am, if you can turn on the video if you are around. Thank you, Dr. Rashmi, for being here. We are now going to do a release of our national training project, Practical Pediatric Oncology, which is the flagship program of PHO chapter. We've been running this for many, many years, and hats off to our seniors who conceptualized this NTP PPO project, which has really changed how we have penetrated the pediatric community and educated them about pediatric oncology, early diagnosis, awareness of pediatric oncological problems, and making them aware of the oncologic emergencies, the referral pathways. And this has really, really, been our flagship program and has helped many, many pediatricians across the country. And this year we have revamped our existing set of slides, because we have this set module which is given to the trainers, and the trainers go into the community and train everyone using those slide sets. Dr. Anand Prakash, who is the NTP PPO coordinator, he's from Bangalore, who is really leading this project, along with Dr. Rachna Seth. Both of them have done a lot of hard work to revamp these slides, and I'll just request Anand Prakash to run through what is being done with NTP PPO, and then request Dr. Guillermo, Dr. Rashmi, and Dr. Shripad to kindly release these slides. So over to you, Anand.
Thank you so much, Dr. Manas. It's really a privilege to present to this audience. Like Manas said, the NTP PPO is one of the flagship program in place way back almost 3 decades ago to train pediatricians and pediatric trainees, and we're now moving to training more nurses and also primary care doctors in the early diagnosis and stabilization of follow-up of our patients. As many of you know, many of you who've conducted these programs have been faculty for us. It started off as a 2-day program and then has moved to a 1-day program with standard lectures, which Manas was speaking about. And we are happy to let you know that the slide set has now been updated, and the next move will be to update the manual. I think for the last 3 decades, we've had more than 100 workshops. This picture has many of the leading luminaries of the chapter here, some of whom have spoken today. And it's quite heartening that SIOP supported one of the first training of trainers way back in November of 1997. And thanks to Dr. Raj Warrior, one of the friends of the PHO chapter, for sharing this picture with us. So when we started off this thought process of updating the important program for training of peripheral doctors, we ran a small survey about a year ago, and we found that most of our members felt that the slide sets and the format of teaching, which was primarily didactic at that time, needed to move ahead, and that participant interaction was something which we needed to work on. And so the process which we followed was, through this survey, we identified some new topics which were required. A request was sent out to 2 faculty, one a very senior member of the chapter and one another middle-level faculty in pediatric oncology, to look carefully to update the content, and also keep in mind that this was for primarily pediatricians, trainees, and primary care doctors. A big thanks to Dr. Rachna Seth, who's worked very closely with our team to have looked through each of these slides and have supported actually getting these slides together. So our existing topics covered a variety of topics. Many of you have been faculty, so you know this list. We needed some new slide sets for brain tumors, approach to lymphadenopathy, lymphomas, and some of the important topics which we've spoken about today: nutrition, survivorship, pain and palliation. And a lot of the pediatricians actually got back to us and said they wanted more case studies. So red flag signs in pediatric oncology and a lot more interactive case studies is what we have. So more than 30 faculty across the country, both senior and middle level, all of them have been listed here. A very big thanks to all of you for having put all of these slides together for us. So in terms of the new additions to the teaching learning methods, all these slides have, besides the didactic components, some MCQs which could be run as quizzes. A lot of you have already taken this forward and have conducted panel discussions for emergencies and panel discussions for shared care, which are key aspects of pediatric oncology training. A lot of pediatricians wanted us to include how to counsel a child prior to referral, because that's what they do, and many of the families just abandon and don't come in if the pediatrician doesn't counsel them appropriately. So a role play has been put into one of the aspects which could be included in the program. Many of you have already conducted quizzes. Many of you have conducted case presentation competitions, which really increases the interest of pediatricians and trainees to not only attend, but take home a lot of the important messages. So even when the founding fathers and mothers of the chapter put this program together, we'll remember that while we currently run the one-day program as the most commonly run topic, there is scope for a half-day program, which could be for medical officers and interns, which would be a little simpler and cover mostly case scenarios and give them an overview. And the original two-day program has a lot of details plus a care blood component use for those who, particularly for those peripheral centers who are actually delivering chemotherapy, and a lot of centers now work with other peripheral centers. So if we need to train things which we could look at. So in terms of the guidelines for the local organizers, a lot of the things which the senior members had suggested in terms of the pre-test and post-test remains the same. The PPTs which have been updated have MCQs. The NTPPPO manual, which was and that been very PO coordinator to actually do the workshop as mandated by the chapter. We did find that many times the certificates were given out irrespective of participants who completed the post-test or who did the feedback. So now we are making it more mandatory that every participant has to really complete the post-test and given the feedback, all this electronically, and only then they'll get the certificate. We've introduced a lot of optional components for teams which want to do this: audience voting, case presentations, panel discussions with pediatric surgeons, radiotherapy and palliative care colleagues, small group learning for case scenarios, role plays, which I spoke about, simulation, taking them actually into
I think there is a network issue
Yeah,
there
Anand, you're
with Anand.
frozen.
So yeah, I think his slides are frozen, but I think he has nicely conveyed the message of, and I think that was probably his last but one slide. So big thanks to Anand and Dr. Rachna for doing this for us and for the entire chapter. I just request Dr. Guillermo and Dr. Rashmi to please say a few words and declare these slides available for use at large.
Guillermo, you go first.
No, please, Rashmi, go ahead.
Okay. Thank you, Manas, for having me here today. And the NTP PPO program is something very close to my heart. Congratulations to Dr. Anand Prakash, Dr. Rachna Seth, and the whole PHO chapter, for that matter, for this fourth revision of the slide set, as well as a very evolved format. So, this whole NTP PPO program, it's started, has evolved and come a long way since it started 26 years ago when we had our first program. And I must acknowledge, the selfless hard work and the vision of my colleagues from back then. I won't go into details of their names, and all the others who have been coordinators over the years for their vision, and for also to SIOP, who actually stood by us, who believed in us, and financially supported us for those initial workshops and the whole program per se. And the whole idea was to sensitize pediatricians, as we now know, that cancer can occur in children, that it is potentially curable, and to empower them with to make an early diagnosis and help us treat them better, to make sustainable outcomes through shared care and other things. And also this stands in line with, now we are with WHO GICC, and it stands in, it's aligned with the fourth pillar on strengthening referral pathways. So congratulations once again, and yes, over to you, Guillermo.
No, I'd just like to echo your words, and on behalf of SIOP, congratulate you for the initiative. It's always an honor for SIOP to support such initiatives, because we know the huge impact they have, because the high quality of the work that is being done in India. This is just another step forward to the great work that you are doing. So I am very proud as SIOP president to continue supporting whatever you do. Please come by. Well, Rashmi is very much involved in the SIOP board for many years, and it's always a pleasure. And the SIOP stores are open always for this kind of great work. So thank you very much.
Thank you.
So thank you, Dr. Rashmi and Dr. Guillermo, for releasing these slides. And again, big congratulations to Anand and Dr. Rachna for doing this great work, and for everyone who has actually contributed to this very useful material. Moving on to the next and the last agenda is a release of our poster, which is the 12 Mahine 12 poster. It is, one of the initiatives of PHO chapter to increase awareness about pediatric cancers across the country. This initiative was recognized by Indian Academy of Pediatrics, which is the body which kind of is the association of 47,000 pediatricians in the country. And this poster is released by our chapter every month, and then is circulated by the Indian Academy of Pediatrics across to all the 47,000 pediatricians. So I'm just going to share this poster on the screen. Dr. Archana has been helping me with this poster initiative, and every month there is one person from the chapter who actually takes the lead and makes the poster. And this month it is Vinay MV. So Vinay and Archana, congratulations to you to really to actually make this poster. The theme of this poster is multidisciplinary care, and I'll request Archana and Vinay to please say a few lines about this poster, and I'll just show you the poster on the screen. I hope it is visible.
Yes, sir. It's visible.
Partly.
Yeah, so this is the fifth poster in line out of the 12 posters that is planned, and this time because ICCD 2025 also was there, so we thought we will connect the dots. So it is titled as Wagon Wheel of Childhood Cancers, the role of multidisciplinary care. The first half of the poster says about the hurdles in access to care in a form of infographic. So where a child who is in a peripheral center, the hurdles they need to face to reach the comprehensive cancer care service. So the most important things that already has been highlighted in the previous talk: lack of awareness, poor referral network, so cultural and social barriers, out-of-the-pocket expenses, and even before they reach the center or in the center, they may abandon the treatment. So what are the ways we can bridge this? A very most important thing will be a pediatrician and with a community connect. So we have labeled him as a Superman who will carry the child and help us take the child from the peripheral center to the comprehensive cancer care. And the bridge will be gapped only if we ensure comprehensiveness that will complete the care for the kid. An acronym we thought we will do, so that is like recognize, diagnose, evaluate, and manage. So redeem a child, and then the wagon wheel, which will be the strongest part of the car to move. The wagon wheel will indicate how a child with multidisciplinary care will come out with flying colors and have a good outcome. I would ask Archana to elaborate on the wagon wheel. Archana, over to you.
Wagon wheel of childhood cancer is an illustration of how we can unite our effort to support the child who is suffering cancer. At the center of the wheel lies the child and their family, emphasizing that our care must evolve around their needs, addressing the medical, social, and emotional needs simultaneously. Surrounding this core are the different medical professionals playing vital role. Among them, we believe pediatrician is a critical link and will play a key role in bridging the gap in cancer care and bringing cohesion to our effort. However, to strengthen the childhood care model, active engagement of government, non-governmental organization, collaborative research, and community involvement are vital. The last part of the poster, that is World Health Organization Global Initiative for Childhood Cancer to attain at least 60% cure rate, explains the 4 essential pillars of action coupled with 3 enablers that remind us that it is possible when we work together to improve the outcome for children with cancer, that is cure all. As we reflect our mission, the key message is united we stand, dedicated we work, we can cure most. Dr. Vinay and I would like to take this opportunity to extend our gratitude to Dr. Manas Kalra and Dr. Ramandeep Arora for giving valuable inputs while making this poster. I also thank IAP PHO chapter for giving this opportunity. Together, let us keep the wheel turning, ensuring that every child receive the care, support, and hope they deserve. Thank you so much.
Thank you, Archana. Thank you, Vinay. Thank you, Raman, for contributing to this poster on multidisciplinary care. I'll request Dr. Guillermo and Dr. Rashmi to please give their comments.
I can
Guillermo,
start
this
now.
time you first.
Yeah, we switch. Yeah, again, warm congratulations. I think this is a very important topic. You are addressing the whole issue from the beginning to the end, and I think you make a good point on the time interval from the time the patient arrives to the healthcare facility until the diagnosis and the treatment is made and the treatment is started. I think it is a very informative poster. I wonder if it comes together with the referral pathway, so we know that we can speed up as much as we can the time from the family gets to the first consultation until the patient reaches the healthcare facility. So it is really a very important work that address the problem in all the dimensions, and and I think it will be very impactful for your work. So congratulations again, and very nice visuals, by the way.
Thank you.
Yeah.
Dr. Rashmi.
I have nothing to say. I mean, I'm quite speechless. This is a really comprehensive and wonderful poster, especially on the occasion of ICCD. And I know you have been sending out these early diagnosis advocating posters every month, and it's going to be for a whole year. So this is a really fantastic initiative, and this poster in particular, I think it addresses all the potential challenges and the solutions throughout the continuum of care. And it's really something great. And perhaps, this can be kind of applied to so many other LMICs as well, this whole concept. So thank you, Dr. Vinay and Dr. Archana. This is a really well-conceived poster. And thank you, Dr. Manas, Dr. Shripad, for this initiative for this year. Thank you.
Thank you so much, Dr. Rashmi, Dr. Guillermo. I now request Dr. Shripad Banavali, sir, to please propose his vote of thanks for this ICCD special webinar today.
Yeah, so thank you very much. First of all, I'd like to thank Dr. Guillermo, Dr. Chantada, because really he's a busy person, but even with that, he's taken out time and really gave a beautiful talk addressing the need of doing research in the basically low and middle income countries. And before that, actually, I would like to even thank our own people, actually, Dr. Rachna Sheth, Dr. Maya, who really brought out the importance of doing survivorship. And unless we have survivors, it's no use basically treating children with cancer. So it's very, very important aspect addressing the needs of that community's cancer treatment doesn't stop at when they complete the treatment, but they need continuous support through entire life, and that was beautifully brought out by these two, and especially Dr. Dr. Purna Kurkure, who has been really spearheading this ACT clinic for many, many years now. And being part of that group in Tata, it's really, I've seen how it has progressed over the years and where it has reached now. So that was that. And again, Vinay and basically the poster is beautifully done, and really it will give important message to the people. Like it has been told, at 12 months, 12 posters. So it's going to be important to continue basically having these posters out, because early diagnosis is very important, because not only it helps save more children, but very, very importantly, we can treat patients with early diagnosis at fraction of the cost that is required to treat patients with advanced cancer. So that's very important. And last but not the least, Anand Prakash and Dr. Rachna Sheth again doing an excellent job of doing revamping the whole NTPPO slides, because that's again the flagship of the society. And over the years, we have been, I really, that first photograph, it looks good. So many of us are still there and working actively in this field. So that's very important. Though we have lost some important people from that photo, and it was really worthwhile, those old memories from the first meeting that was done in Mumbai at Wadia Hospital years back. But definitely it's a very important flagship, and it's so great that we have continued doing that over the years, and it's really still it's very popular in whether last year, like Anand just put out 16 NTPPO programs were done last year, and every one of them was attended in a big number. So I think again we have to continue this initiative and do more such talks. But thank you once again. Thank you, Dr. Chantada, for being with us till the end. And thank you all of my colleagues who have attended for this talk. And last but not the least, the most important person, Dr. Manas Kalra, who is so dynamic and really has really helped us to keep all this program together. So thank you, Manas, for all the hard
Thank you,
work,
sir.
and the
Thank
entire
you.
team, and Shruti also. I forgot Shruti there. So many. I'm really sorry if I missed any names.
No, no, no.
But we have a really young team. You can see I'm one of the old men out here, but most of the team is so young that we are really very pleased to have a young team working for this thing, and it's really good for the future of pediatric oncology in the country. So thank you, everyone.
Thank you, sir.
And
Thank
good
you for
night
the
to
kind
everyone.
words. Thank you. So I wish everyone a happy Valentine's Day also. If your spouses, partners are angry with you, please go back and then spend
Bye.
some time with them. Happy Valentine's Day. We'll meet again on 27th when Dr. Simon Bailey is going to speak on medulloblastoma in the international webinar program, and we'll circulate that information very soon to all of you. Thank you, Dr. Chantada, once again. Happy ICCD, all of you. Thank you.
Dr. Archana also, I forgot her name. Dr. Archana, thank you for the poster.
Thank you, dear friends. Have a nice day.
Thank you. Good night. Good day to you, Dr. Chantada.
Thank you.